All right, so we have a 2019 annual scientific meeting at Mohegan Sun, and I've been asked to present some oral surgical information. So the course topics that I'm going to be talking about at that meeting, I'm not sure if all of you will be at that meeting or not, but it's going to be a relatively comprehensive 3 days discussing pre-surgical medical history and surgical consent forms. I'd like to talk about some complications of extractions, understanding some adjunctive biologic proteins for wound healing, socket grafting and ridge preservation, oral pathology review with an update in the HPV epidemic that has been occurring over the past many years and its effect on oral and pharyngeal cancer. We'll talk a little bit about some surgical procedures with the CO2 laser. I'd like to discuss some biopsy methods and techniques that can be done in your office, and also talk about implant planning. And I think a very exciting new innovation is going to be the placement of implants and actually doing some surgical procedures with virtual navigation. In conjunction with the didactic portion, there's going to be 9 hours of hands-on laboratory, and I'm working on that right now, and I think that's going to be a worthwhile experience for everybody also. So I look forward to seeing any of the attendees that are on tonight's webinar at that meeting. So this blended webinar learning, I've been told, is to kind of give you a little bit of a taste of what we'll be talking about at the annual meeting. And this evening's tonight webinar by no means is a comprehensive overview of the topics we'll be talking about. You know, most of the topics that I have listed take many hours or a half a day to present all the information. So in this hour-and-a-half presentation, I'm just going to give you some tidbits to get you thinking about some of the things that I think are important for general dentists to do oral surgical procedures. You know, over the years, I've been fortunate to present to the AGD at their, I think it's the, not the Maxi course, but the Master's Track course. And I've done that over a number of years now. And I've really enjoyed that because I found that most of the general dentists within the AGD really are very qualified, competent practitioners who really want to learn more and are able to do a lot of the things that expand into some of the surgical specialties. So as long as you're aware of what's going on and become well trained and know how to deal with some of the things that you'd like to take on, I really have no problem seeing general dentists expand their scope of practice. So with that, I'd like to talk about a little bit of an overview of pre-surgical medical history and consents, because without understanding what's required of you prior to starting surgical procedures, I think you're headed for a world of hurt, because we all have complications and problems, and we all have patients who have great expectations. So without understanding how to avoid some of those complications, or at least make patients aware of the risks and the benefits, going through pre-surgical medical histories and what type of consents are required, I think is important. I think that another very important aspect of general dental treatment, especially because everybody is so interested in doing implants, is recognizing how important socket grafting is and ridge preservation is when we're taking out teeth, and how we can begin to start the conversation for the future dental treatment plans of our patient, and how by performing ridge preservation and making sure that we have adequate volumes of bone, we can much more easily place implants in the future. And then with that being said, what's the best bone graft materials to use? What are some of the new adjunctive materials that we have for some of the various procedures that we'll be doing, not only with socket grafting, but with onlay grafting, or maybe some sinus grafting or some sinus intrusions. So if we have time, we'll discuss some of those things also. So let's kind of begin a little bit. I was told that I need to kind of give you a disclosure. I am getting an honorarium from the AGD for this presentation, and I will be getting one for the scientific meeting, so thank you very much for that. Although we're not going to be talking about some of these things this evening, I do have a proprietary interest in XNAV technologies, which we'll be talking about at the meeting and at the next blended webinar. And I'm the developer of the 10 screws that are being marketed by KLS Martin Surgical, and also the fixture mount transfer component that's on many of the major implant systems today, as well as on the Zimmer implant system. So that's my disclosure. So let's get started with the topics of the evening. And certainly feel free to enter any questions that you have during this presentation. Sometimes when you just speak about certain things, it needs a little bit of clarification. And rather than wait till the end of the presentation, I'd rather address them during the presentation. I added to this little CV here that I was the National Dental Advisor for Medical Protective Insurance Company from 2012 to 2017. Medical Protective is probably the insurance carrier for some of you that are out there listening, but most importantly, it's one of the largest malpractice companies in the United States, insuring a number of medical practitioners as well as all aspects of dentistry and all dental specialists. So as a result of being a dental advisor, I've had the opportunity to really see some of the malpractice events that have happened. And so many of them happened because of an inadequate medical history that was taken or a inadequate consent that was filled out, on behalf of the patient for the treatment that they were having. So I think these are very critical issues that really need to be addressed and become part of your practice. And let's begin the discussion at this point. So what are some of the important questions when we talk about pre-surgical medical history? And I think those questions are, how often is it required to update a patient's medical history? What are the main concerns when we're performing oral surgery? What preventive measures are helpful in a successful surgical outcome? How complete is your explanation of complications for the procedures that you're going to be doing? And how complete is your consent form, and how often do you use it? I've noticed that in general dental practices, you have a relationship with your patients, and it's not very common to go through a consent form for every single dental procedure that you're providing. But once you start doing procedures that are actually done by specialists or specialty procedures, you do have to follow the protocol that's required of those procedures and the protocol used by the specialists in your areas that are providing those services. I think that's critical. So let's kind of review some of those things, briefly. So how often is it required to update your patient's medical history? And in red, I've answered the question for you. And the answer really is at every surgical visit. And not only do you have to review the medical history at every surgical visit, you need to document it with the date, preferably have the patient's signature, and preferably have a witness. Because each time you see a patient and you're providing surgical services for that patient, you need to know from the previous visit you saw that patient whether anything had changed in that patient's medical history. And it can be something as innocuous as a change of medication, not just a change in their health, although medication may be obviously a significant indication of a health issue. So at every visit, it's important for someone, usually your front desk, to ask them before they come in, has there been any changes in your medical history, the medications that you're taking, or anything that we should know about? From a surgical point of view, what's important that we want to know about when we're asking our patients within their pre-surgical medical history that might affect our surgical outcome? Well, obviously, when we're doing surgery, we kind of always think about bleeding. We're using medications that can, without question, affect the cardiovascular stature of the patients. Today we've got patients that are on, have all types of pulmonary issues, but more importantly, smoking. And what I'm finding also is very important is the smoking of some of the vapor cigarettes that are out there now. The amount of CBD that's being used by patients. So be aware to ask them not only do they smoke, but what they smoke. There's no question there's an increase in renal failures. Our patients are psychologically affected by coming into a dental office, and that may have some significant effects on how they feel at the time of their treatment. Systemic issues are always a problem. It's kind of interesting. I was going through some literature myself, and I didn't even realize that 40% of patients over the age of 30 have some type of systemic medical issue. and 50% of our patients over 40 have the same issue. And as we get older, and I'm sure you're very much aware of this, our older patients may have numerous medical issues going on, and we'll talk about that in a little bit later also. Allergies are very critical to know about. Even food allergies are important to know about. I just had a patient in today who has all kinds of food allergies, so much so that the foods that this particular patient can take pre-surgically or post-surgically are going to be very difficult, because she can't take any liquid products that have so many different things that we would typically use for post-surgical patients. The initials TJR are not anybody's initials. It stands for total joint replacement. The amount of total joint replacements or implants that are being used on patients today is just exponentially increasing. So what do we need to know about those patients, and how should we treat those patients in regards to our surgical treatment planning? And medications that they're taking, how that's going to have an implication on healing, and so many other things that you need to think about. So I think that this is an important slide, and keep an eye on some of those things. What about preventive measures that are helpful in a successful surgical outcome? We all want surgical outcomes that are happy, that yield us a happy patient, and a product or a treatment plan that's going to be able to be continued and well served for the patient. But in order to be able to have a successful outcome, we need a well-prepared patient that understands all the risks and benefits of that procedure. I can't stress enough how important that is, that the patient really is a participant in their ability to have a successful outcome. I think we need to have appropriate pre-surgical medical management. Is the use of antibiotics, anti-inflammatory medications, anxiety medications if needed, is that going to help us get a better surgical outcome? And what if the patient does have some medical issues? Maybe we should get a medical clearance on that patient. And I think something that's also often forgotten is we need a well-prepared doctor performing the surgery, having all the appropriate supplies and equipment necessary, not only to treat the patient, but any complications that may arise during that procedure. And if it's not a complication, just an alteration of treatment plan, because sometimes what we expect is not necessarily what we're able to deliver for that patient based on what we see at the time that we get into the surgery. So those are some of the things I think that are important. But also, before we start our surgery, we really have to have had that discussion with the patient of what we're doing. So how complete is your explanation of the complications? Because every procedure we do does have potential complications. How complete is your consent form, and how often is it used? That's really a big question, because a lot of patients don't even look at their consent form. In fact, that's one of the reasons in a malpractice case, consent forms sometimes don't necessarily always get you out of a problem, because patients will say, hey, I just didn't read it. I didn't understand some of the words in it. So it's important to understand how your consent form looks, how it's used, how it's given to the patient, and then how the explanations are described. Does it list the risks and benefits of the procedure? Are alternative treatment plans discussed within your consent form? Is there a witness to the discussion and the consent? And most importantly, is your consent specific for the procedure and risk? So many times I see one consent form that simply lists the procedure and then asks the patient to sign it, without a lot of information going on in regards to the specific procedure that's being talked about. So just today, and I don't have this as a slide, but just today I did a biopsy on a patient. And I just thought that this was interesting, because I looked at my office records. And for this simple biopsy, that was just a little bit of a fibroma and a little bit of some leukoplakia type lesions on the gingival tissue of the mandible. I had 3 consent forms for that particular patient. I had a specific consent form for the biopsy. I had a specific consent form for bisphosphonates because we really need to be aware of some of the significant adverse effects of some of the medications that our patients are taking, and they need to be aware that some of those risks are on them because of the medications that they're taking. And this particular patient wanted some IV sedation, so we had a separate consent form for the anesthesia that we're using. So here's a patient for a simple procedure, and we have 3 separate consent forms. And you may say that's a little bit of an overkill, but it's actually the minimum adequate requirements in order to protect yourselves from having any problems. So that being said, and we have the consent form signed, patients well informed, what are some of the surgical and medical considerations for some of the dental surgical procedures? And what's interesting, I was thinking about this before also, why is it just surgical procedures? I think all our dental procedures in some way are the same as any surgical procedure. So don't take things lightly just because we aren't taking a scalpel to a patient. Patients get nervous, they get local anesthetics. Things can happen to patients who've got medical issues with some of the most simple dental procedures that we perform. Remember that the medical evaluation of a dental patient should be no different than the evaluation a patient receives for any surgical procedure. That was a statement made by the American Association of Oral and Maxillofacial Surgery in the Office Evaluation Manual that's given to all oral surgeons that are taking the anesthesia review for their ability to be able to deliver anesthesia in the states that they practice in. You know, we have a number of different risk factors that we see in surgery every day. We've got medical risk factors and we have surgical risk factors. And then again, I have dental there because I don't want to separate some of the dental things that we do from some of the surgical things that we do and the fact that they pose certain risks. So let's take a look at the medical and then the surgical, risk factors that we have. The complex medical problems of our patients demand our understanding of the physiologic, psychological, and pharmacological effects of the medications and the surgery that we're doing. This is kind of interesting, but today's patients that are often being treated have more than 3 medical issues that they have. And if they have 3 medical issues, just imagine the numbers of medications that they might be on. And don't forget to ask our healthy patients about some of the herbal medications that they think that they might be taking to help themselves, which do have some effects on bleeding and other things that might affect our healing. So make sure we ask these patients not only what medications that they've been given by their physicians, but what medications they take on their own, for their own well-being. So what are some of those medical risk factors that we're talking about? You're all familiar with these things, but let's kind of review some of them. Cardiovascular disease is on the rise. Pulmonary disease, as we talked about before, from smoking and COPD. And actually, I was thinking about this also when I was putting this lecture together. I didn't want it to become too burdensome. But one of the things that general dentists are doing more and more of is treatment of sleep apnea. Well, sleep apnea is a pulmonary issue. So if you've documented a patient with sleep apnea or are treating a patient with sleep apnea, you now have a patient who does put themselves at an anesthetic risk. So be aware of that also. What about our patients who've got endocrine problems or renal problems? More and more of our patients have these autoimmune diseases, whether it be rheumatoid arthritis, whether it be lupus, whether it be any of these numbers of autoimmune problems. They have tremendous effects not only on being able to treat these patients, but their ability to heal and how they respond to some of the things that we do, because these collagen diseases, these autoimmune diseases, have a significant effect on wound healing. So we'll talk about that in a little bit also. What about our patients' psychological, effects? I have a very, very difficult time dealing with patients sometimes who just are so nervous or so challenged once they get into the dental office that they become very difficult to treat. So there's a risk factor just in treating those patients. And unfortunately today, cancer's on the rise. A lot of these autoimmune problems are on the rise. So the numbers of patients that are on chemotherapeutic agents, biologic agents, we need to be aware of them. We need to be able to time the treatments of their medications to the treatments that we're going to be doing to make sure that they're at the most optimal time as opposed to at the most compromised time. So those are some of the medical risk factors, but we also have surgical risk factors. And those might be the degree of surgery that we have to perform on those patients. It might have to do with the anatomy that's adjacent to the surgical sites that we're operating on. That might also have to do with the quality of the soft tissue, whether it's a thick biotype or a thin biotype, whether it's scar tissue, whether it's been previously surgerized tissue. You know, we need an adequate blood supply in order to be able to get good wound healing. So sometimes we have to be able to recognize that some patients may not have a good blood supply to a certain area, and that might affect the way we want to go ahead and treat that patient or the materials that we'll use to treat that patient. So recognize that having a good blood supply, having good closure of our surgical sites, more often than not, you know, a double-layered, tension-free, watertight closure is talked about, and we'll talk about that a little bit later also. And then what about the post-operative management of the patient? You know, these patients need to be told what their responsibility is in order to get good wound healing. So the post-operative management is also something important to discuss, whether they need antibiotics, whether they need medication to keep swelling down, oral rinses or whatever, whether they need to be cautious on how they blow their nose for sinus precautions. So all these things have to be discussed to minimize the surgical risk that these patients have. You know, as dentists, most of our treatment poses minor anesthetic risks due to the large use of regional and controlled inhalation and intravenous medications. But be aware that adverse reactions can occur anytime. So just because a procedure is simple or appears to be simple, don't think that there's no risk of any problems. And I'm sure you're all aware of that, but I just wanted to make sure we reiterate that. So what are some of our most common adverse reactions? I think syncope is right at the top of the list. It's just something that happens physiologically. People are in the dental chair. They get nervous when they see the needle, the injection. Patients can experience high or low blood pressure just as a result of being on cardiac medications or just from nerves, tachycardia, hyperventilation, anxiety. These are the simple, most common adverse reactions we see in our practice, whether we're doing those simple dental procedures or any type of surgical procedures that we're dealing with. So be aware of recognizing how to deal with these patients by positioning them in the chair in a way that we're not going to affect them, making sure that your environment is such that the patient's anxiety levels are reduced, and all those things, okay? You know, the American Anesthesia Society has a classification of operative risks. And I just thought that this is important to review also, because we should be kind of living within that first three classes of this classification. You know, class one, there's no organic, physiologic, biochemical, systemic, psychiatric disturbances that would involve any procedure. It's a healthy patient. So those are the patients that we can kind of treat, really just recognizing they're normal patients, and whatever might be their issue is their issue. The class two patient, well, then we're starting to have the moderate systemic disease, maybe a well-controlled hypertensive patient, an orally controlled diabetic patient, anybody who's controlled but does have some type of systemic disease. would be that class 2 patient. Now, the class 3 patients we're seeing all the time. These patients have some kind of systemic disturbance that's requiring more significant medication, puts them at jeopardy for having some type of an adverse reaction, a vascular complication, patients with heart disease, patients who are being medically managed. I look at all class 3 patients as patients who I need to have some help with. I want to be sure that they're okay to have elective surgical procedures. So all our class 3 patients get a medical clearance. And I can't stress that how important it is for us as dentists to recognize that we need some help in assessing our patients. And if our patients are being taken care of medically, I think it's incumbent upon ourselves to get a medical clearance and an approval and some guidance on how we can proceed most safely with those patients. Once we start getting into class 4 and class 5 and class E patients, we shouldn't be treating those patients. They should be treated in the hospital. They're life-threatening patients, and only in the most significant emergency procedure would we ever consider doing anything on those patients. So we live in class 1, 2, and 3, and 4, 5, and 6 are not part of our practice. So let's just kind of talk about some of the most common patients that we see and talk about how we should look at those patients before we start our treatment. And I think hypertension is really right up there with those patients that we are seeing. So hypertension, by just a simple definition, is a sustained elevated blood pressure. So patients who have a diastolic pressure under 110 without symptoms, well, they may not need pre-surgical treatment. They probably should be aware that their blood pressure is elevated, but they may or may not need to have any kind of pre-surgical treatment. But 25% of patients that are under control, just being in the dental office, just being given local anesthetic, may become hypertensive. And 20 to 30% of those same patients may develop hypotension. So be aware that just because a patient is well controlled or states they're well controlled, or you start their procedure off with a normal blood pressure, be aware that it can change as the procedure persists. In our office, any patients who have diastolic pressures over 110 millimeters of mercury, they don't have elective procedures. They need to be told that they need to get a medical consultation. They need to get their hypertension under control, and then have the medical clearance to come back and then be treated. You know, a lot of our patients are cardiac patients. Well, you can say that hypertension is a cardiac patient, but I'm talking about patients who really have had some type of cardiac issue, whether it be an arrhythmia, whether it be a heart attack, whether it be previously placed stents, whether it be any one of those things. Well, those patients may or may not be on medications. They may or may not be sensitive to some of the epinephrine that we're using. They may or may not be sensitive to even the nitrous oxide that we give them. We have to be aware of congestive heart failure or left heart failure for patients that we give nitrous oxide to. You know, some of our patients are very sensitive to fluids. Now, in most general dental offices, I don't think we're giving IVs, but patients may come in dehydrated or post-surgically may not drink adequately and become dehydrated. So these cardiac patients are very sensitive to those problems. So be aware of your cardiac patients that you're treating, and be aware to give them the instructions about proper nutrition and hydration following their surgery. And the next one I think is really important, and that's anticoagulants. You know, we're seeing a tremendous number of patients on a variety of different anticoagulants, and some of these newer ones, not the Coumadins that we can kind of figure out where those patients are at, but some of these novo anticoagulants, such as Eliquis or I think Lovenox or some of the other ones. You know, these are medications that are kind of difficult to manage, and they're usually given to patients who have atrial fibrillation or one of those types of medical issues. So we have to determine whether the risk of going off those medications and then having some type of a post-operative cardiac or neurological complication like a stroke is worth going off it based on the procedures that we're doing. So many times we are very reluctant to take patients off anticoagulants when we know we can manage their surgery and their bleeding, intraorally, relatively well. So that's something to think about also. And again, you should be able to speak to your medical colleagues who are treating those patients, because I think all those patients should have some type of medical clearance. So what about cardiac conditions that might require some SBE prophylaxis? This is really always a moving target because the prophylactic guidelines by the AHA are constantly changing. So again, do we need prophylaxis for prosthetic valves? Well, I think we still do. What about patients who have previous history of subacute bacterial endocarditis? I think those patients need to be protected. Depending on the type of congenital malformation that a patient has, they may or may not require pre-surgical antibiotics. Anybody with rheumatic heart disease, I think that patient will be well served by antibiotic prophylaxis. Now, depending on the type of vascular surgery and its location, they may or may not require it. Depending on the type of cardiomyopathy a patient might have, again, they may or may not require it. But again, all these decisions I don't think should be made necessarily by the dentist, but by the cardiologist taking care of these patients. So be aware that the guidelines are constantly changing, and sometimes they're hard to interpret for the patients that we're operating on because they have different degrees of some of these broad categories that even though it may be suggested that you don't need antibiotic prophylaxis, maybe that particular person does, especially because of other medical issues that they might be having that may make them a more compromised patient. So cardiac conditions that maybe are not requiring prophylactic antibiotics would be, non-grafted septal defects, coronary bypass, mitral valve prolapse without regurgitation, functional murmurs, cardiac pacemakers, and stents. Those patients, I think, are pretty well protected without having appropriate antibiotics or pre-surgical antibiotics. But remember now, if we're doing a procedure on a patient that requires, in your mind, antibiotic therapy for the procedures that we're doing, we can cover them for both those things, the procedures that we're doing and the prophylactic use of the medication for whatever cardiac issues that they may have. Now, this next one I think is really kind of interesting. I believe it was in 2014 that the ADA and the American College of Orthopedic Surgeons made recommendations that, for prosthetic joint replacements, whether it be total or partial joints. And in that recommendation, there's a comment made that the likelihood of developing a allergic reaction to the medications might be far greater than a prosthetic joint becoming infected by not using the antibiotics. But at the end of the article that talks about it, there's a little bit of a caption. And what that caption says is, it's up to the operating surgeon for that patient to make the final decision on whether that patient should require post-surgical, pre-surgical antibiotic prophylaxis or not. Because within the confines of the article, it doesn't talk about the complications that the patients might have had for their joint replacements. It doesn't talk about the vascularity and some of the other things that might affect these patients long term. So always ask the patient to get the recommendations of the orthopedic surgeons that are taking care of them. And my recommendation is, when in doubt, prophylactically treat these patients. But what about dental implants? Do we need any prophylaxis for them, or intraocular lenses, or fracture hardware? Well, these prostheses, these implants that are non-movable, okay, that really don't undergo any real changes in position, well, they may not need antibiotic prophylaxis. In fact, I think in the past we really have never done that. But a recent article just came out, and I just put this in, what about breast implants? And I didn't realize this, but according to the plastic surgical journal that I just read, the incidence of contracture and infection of breast implants may be related to dental treatment. So I think it's kind of incumbent on us to really kind of research this out a little bit more. And maybe if we're inquiring on our patients about having previous surgery, especially women patients, if they have had breast implants, maybe it would be advisable to speak to their plastic surgeon to see whether or not he would recommend antibiotic prophylaxis. Okay, so what are the things that are going to convince us not to do any surgical procedures on patients? Well, I think that would be uncontrolled systemic disease, radiation treatment maybe within the last 3 years. And if we do need to treat these patients, we should be aware that the complication of osteoradionecrosis is really significant. And maybe these patients should be treated with hyperbaric oxygen pre-surgically and post-surgically to minimize the risk of osteoradionecrosis. And I think if a patient has untreated pathology in the area that we're doing surgery, that needs to be dealt with first, and it would be a contraindication to doing our planned surgical procedure. So I think that that's kind of very telling. This is a patient who I had operated on a number of years ago, and he had tattooed on the inside of his lip the word biohazard. And I have it in there because, remember, anytime we enter a patient's mouth, it may be hazardous to the patient, but it also may be hazardous to us. So I just thought that was a pretty cute slide, although I have no idea why he wanted to print that on the inside of his lip. But I do think he was the involved with a band with that similar name. So let me just kind of review one case that came up when I was an advisor for a medical protective, because I think this is kind of an interesting case, done by a very qualified general dentist, or it was within the general dentist's office. It was a 48-year-old male with bilateral knee replacements done 20 months ago, not quite 2 years before, but 20 months ago. The patient had a history of degenerative osteoarthritis and had previous knee surgeries over the years and had done well, but he had multiple surgeries. Otherwise, the patient's past medical history was relatively normal. His dental history was relatively normal. He was an occasional smoker. He did have some social alcohol, and he admitted to doing multivitamins. So probably call this patient a class 1 or a class 2 patient, one that we all would treat in our practice without any problem. He wanted to have some dental treatment done, so he called for an appointment to his dentist, who he hadn't seen in a while, and he was appointed with the hygienist for some scaling and cleaning, with some intraoral x-rays and a Panorex, and then he expected to be examined by the general dentist for his treatment planning for future work. So the course of events was the patient was well known to this practice, but he had not been in the office for 4 years. He wanted to have routine care started, and that's what the purpose of the appointment was. The appointment was scheduled by the front office. The hygienist saw the patient. She reviewed the past medical history prior to doing any treatment, and she recognized the need for possible antibiotic prophylaxis because of this patient's bilateral knee total joint replacements. The hygienist appropriately asked the dentist whether or not this patient was going to need antibiotics, and he had stated that there was no longer any need per the ADA and the American Society of Orthopedic Surgeons to put the patient. Now, the patient had previously always taken pre-surgical antibiotics, and he questioned this. There was no call made to the orthopedic surgeon, and the hygienist went ahead and started to treat this patient. And the treatment was just a deep scaling and curettage, and then the x-rays, and that was all that was done for the patient. And so the discussion points are, would antibiotic prophylaxis been needed for this particular patient? And remember what that caption had said, when in doubt, speak to the orthopedic surgeon. What notes need to be in the chart if we decide to treat these patients? And I think that note should be that, we contacted the orthopedic surgeon. These were the recommendations. Or if we decide to do something that would differ from that, the reason that we're doing that. Should patients with a significant change in their past medical history be scheduled for treatment? I'm not sure that they should. I think patients who haven't been seen in 4 years may need to come in for consultations and review with them what's going on, renew the relationship with the patient, and then schedule the patient for treatment after the adequate medical history is taken and a determination is made of what the best thing should be done. And remember, I think the final decisions for treatment rest with those practitioners who are taking care of the patient. And again, recognize what the ASA risk is of that patient. Do we have any questions yet? Just curious. Everybody pretty good so far? All right. So let's talk about this particular patient. Post-operatively, at 7 days, the patient had mild swelling of the knees and pain. The orthopedic surgeon saw the patient at 10 days. Patient was then diagnosed with bilateral septic knee joints. He was operated for bilateral revisions at 2 weeks and had post-op limited mobility and pain. This particular patient sued the dentist, and there was a patient verdict in the high 6 figures for this particular patient. So just something to be aware of. Something that was pretty innocuous ends up becoming a malpractice nightmare. All right. Is everybody hearing me okay? Can I get some feedback?
Yes, we hear you well.
Okay, I just want to make sure, because I'm just wondering if all of a sudden it didn't go through and I'm just talking to myself in the screen. So,
no, you're fine, Dr. Rosenlicht.
Okay. When we talk about complications and problems, you can't help but talk about the need for equipment that you need to have in your office. Do all of you have complete emergency kits with up-to-date drugs and equipment to maintain the airway, or if appropriate, to intubate? Even if you're not capable of intubating, if you were to call somebody to your office, like a 911 or medical providers, they would like to have the ability to be able to have the equipment in your office to treat those patients. Do you have appropriate blood pressure monitors? Are they on the patient when you're doing treatment? Do you have a cardiac defibrillator in your office? Are your records up to date in regards to your office compliance with basic life support and emergency drills? Are you having periodic emergency drills? Does your office know to call 911 when there is emergency? And if they do call 911, do they know what to say, what to do, and how to perform the emergency that's going on in your practice? We do it every 3 months. So I think that that's something that people need to be aware of. And remember, if you do have a complication or a problem, plaintiff's attorneys look at all these things. They look at your preparedness to deal with these emergencies. So think about some of the interesting events that may have happened in your office. Think about how they were handled. Were they handled well? Could they have been avoided? Or what was the issue? So I think that's very important. And whenever we do have a complication or a problem, whether it be minor or significant, we do a timeout afterwards and make sure that everybody reviews what has gone on so it doesn't happen a second time. So that's a very, very broad overview of pre-surgical, medical history, pre-surgical planning, consent forms, some of the things that you need to be aware of. It might be a little bit rote. Maybe many of you are aware of it already, but I think that as you expand your practices to do more and more things, be aware of what's required for you. What I would recommend is that you contact your malpractice carriers. They have specific consent forms and they have specific guidelines for you. So take advantage of that to make sure that you have within your practice the things that they're recommending that you need for appropriate protection and care. So let's move on to some surgery here now that we've got our healthy patients and we're ready to move forward. And I think one of the most common things that you should be doing as general dentists, especially general dentists who are taking out teeth, is bone grafting. Okay, I think it's an important part of the treatment that you want to be able to offer to your patients. So when we talk about bone grafting, what are we talking about? Well, I think we're talking about ridge preservation and socket grafting. I think we're talking about onlay and inlay grafting and understanding the differences between those two things. And if we want to get a little bit more sophisticated, we can talk about sinus grafting, because these are the three most common intraoral grafts that we're doing for patients who may or may not be interested or want to have dental implants. And I think that that's something that's obviously becoming more and more prevalent in all our practices. So what does bone grafting do? And why do we want to do it on patients? And I think it's a very significant procedure that offers a tremendous benefit to our patients because it preserves the integrity of existing bone. It maintains the osseous form and function. It supports our overlying soft tissue and any components we put on it, even if it's just going to be some type of conventional bridge or denture or a partial. And if we do some bone grafting and patients are unsure of what the treatment plan is going to be, at least we've maintained the ridge to give them an adequate amount of time to decide on what the future restorative process might be. So when and why should we do it? Well, I think we should be doing it on any patient that we're taking out teeth on when we're contemplating placing endosseous implants. I think we should do it on patients who we want to protect vital anatomical structures. And I think we want to do it on patients when we want to prevent further atrophy, weakness. We want to maintain the integrity of the bone, and for future aesthetic needs, maintaining these particular patients. And we'll talk about immediate repairs, immediate replacements to maintain aesthetics also. So if we're interested in doing bone grafting, how and when should it be done? And why is it so confusing and oftentimes so challenging, and sometimes it can be complicated? Because it really can be, and it is confusing. And one of the reasons why it's confusing is a pretty simple answer. And I look at it as not all patients are the same. We just talked about that. Not all graft materials are the same. We'll talk about that in just a second now. Not all defects are the same, so we treat them differently. Surgery is not always done the same way by different practitioners. And most importantly, surgeons don't see things always the same way. Okay? So I think that that's important to recognize. So the first thing that's important to recognize is that we have a number of graft materials to choose from. Now, I'm not going to talk about some of the newer type adjunctive materials we can use. Let's just talk about some of the basic graft materials that we have. And you'll notice that you have autogenous bone in the middle. And what this slide shows is kind of a timeline. It's not giving you a time necessarily, but it's showing that on the left-hand side, we have highly resorbable or soluble materials. And on the left side, we have insoluble, non-resorbable materials. And they all have different characteristics. And sometimes we need to pick the material that's going to last as long and be able to remodel for that particular patient's defect, age, medical ability to heal, and so forth. So you can see on the resorbable side, we've got demineralized freeze-dried bone or mineralized freeze-dried bone. But again, that can vary based on the particle size of the materials that we're using. We can use some synthetic materials that are resorbable or soluble, like tricalcium phosphate or beta tricalcium phosphate. There are other graft materials that we have on the market, Ceresorb and some of the other materials that we have. And then we have autogenous bone that might be harvested from our own patients, or we have allogeneic bone, such as J block or Puros blocks that are from other human cadavers that are similar to autogenous bone but are processed. And then we have the xenografts, the anorganic bovine bone, and then we have the insoluble non-resorbable materials such as HTR and hydroxyapatite. Sometimes we can even composite these materials to get the benefits of them used in conjunction with the needs of our patient and the defect that we have. We also have these synthetically engineered stimulatory proteins. I'm sure we're familiar with GEM21 or MDGAIN or recombinant bone morphogenic protein or P15. These are synthetically manufactured proteins that we can use in conjunction with our grafting and our materials, or we can even now use naturally synthesized materials from our patients, platelet-rich plasma, PRGF, amniotic stem cells, or even engineered autogenous cellular components that are becoming more and more popular in all our fields of medicine now. So these are things that we need to think about when we have patients who might be compromised, who have previously failed grafts, and we need to have something to help them heal better, in the future. Now, I said before that patients are different. Well, the defects are different too. So some of the defects that we have to deal with are sockets when we take out teeth, maybe cystic defects that we have within, our bony confines of the maxilla, the mandible. Defects can be vertical defects, they can be horizontal defects, or combinations of both of them. And again, these are much different defects than the tooth socket defects. One of the things I spend a good deal of time talking about, and I will when we get to the program in July, is the maxilla is membranous bone, the mandible is endochondral bone. They're two different animals, and you sometimes have to treat them differently, and they heal at different rates. What about the size of the defect that we have to deal with? That's going to affect the type of healing that we're going to have, the amount of material that we're going to use, and whether we'll use adjunctive material for that in order to stimulate healing, because of the blood supply may be less in our larger defects than in our smaller defects. And something that's not considered often enough, in order to have a successful outcome for most of our grafts, we need to have good quality soft tissue. We need to make sure that our grafts are protected and we're able to get a non-tension closure, protecting that graft. We also want to immobilize that graft, just like we want to immobilize our implant, because that's what's going to be important for a successful bone graft to take place. So here, when we talk about successful bone grafting, we want to make sure that we have the right graft material, because that's going to act as a scaffold. We're going to make sure that we have the right donor site preparation. And donor site preparation has as much to do with the preparation of the bone as it does with the soft tissue. Before I start to plan my bone graft, I'm designing the flap to make sure I can adequately cover the augmentation that we're going to be using. Now, just like dental implants need to be immobilized, your graft also needs to be immobilized. So it needs to be protected from overlying pressures, overlying mobility. Otherwise, your grafts will not remodel into firm bone, but you'll develop soft tissue, you'll develop resorption, and not be able to have successful outcome. So our grafts do need to be protected. Again, our flap design is going to be critical, and the preparation of the underlying bone to increase the vascularization is also going to be critical. And some patients heal quickly, some patients heal slowly. I think that has to do with a lot of issues. So you may need to assess and use your own time frames for different types of procedures. Oftentimes I'll do a socket graft, and I feel relatively comfortable in most of my patients to go ahead and place implants into those socket grafts at 2 months. Sometimes I'll have to wait 3 months. Sometimes I'll have to wait 4 months, depending on the size, the quality, and the testing that I do before I decide to put the implants into those grafts. Because we do test them, we do examine them radiographically, and we'll examine them by placing a probe into that graft with some local anesthetic to make sure that we have firm bone underlying that soft tissue. And then again, maybe we'll use some adjunctive therapies to kind of really stimulate this graft, make it heal quicker than had we not used it, or we risk the graft from not taking. So what are some of these adjunctive therapies that I'm talking about? And I put this up here. I think that in order to be able to determine what we're going to be doing and what we're going to be using, you need to be good at your diagnostics. So cone beam imaging, I think, is really very important to determine the quality of the underlying bone, the size of our defects in 3 dimensions, and really helps us determine what our approach is going to be to our grafting. Whether we'll use resorbable or non-resorbable membranes, whether those membranes will be rigid or flexible, whether we want to use some stimulating growth factors, as I talked about before, whether we want to use some stem cells, which we've been using a fair amount of lately. You know, I also think some adjunctive therapies would be the use of prosthetic surgical guides, either for bone grafting or for implant placement, and navigational planning, which I think is going to be critical and part of our future of surgery. Just like scanning is becoming more and more a part of our ability to make models and get those models to the patients without taking impressions. I think navigation is going to be our planned approach for doing a lot of our surgery without the use of rigid guides, and we'll talk about that also at the next webinar, and we'll also talk about it at the meeting. So let's talk about that tooth extraction, okay? Let's talk about filling a defect or filling a hole as opposed to that augmentation, that vertical or horizontal bone loss that has to be augmented. So filling a defect means that the defects have bony walls to support the graft, and building a defect means that they lack a bony wall and you have to offer one or supply one for that particular graft. And there's no easier way to determine that than by a cone beam, because there we can see the dimensions of the bones that we're dealing in. We can see the thickness of the cortical plates. We can see the lack thereof of a bony wall. We can project whether or not we're going to need rigid membranes, tense screws, what type of bone graft material we want to use. So all those things are important. And again, diagnosis is going to be critical for a successful outcome. Okay, so let's talk about the most common bone graft, and one that I think that should be within the armamentarium of every general dental practice, and that's socket preservation. That's socket grafting. It's an inlay graft that's placed within a walled defect. So when I look at a socket where we're taking out a tooth, we have 5 walls that can contain that graft. The only wall that it doesn't have would be the crestal area where the tooth was taken out. But there's a buccal wall, a lingual wall, a mesial wall, a distal wall, and a floor. And I think that confines that graft. And as long as we have adequate blood supply and then adequate protection of that graft at the top, and we'll talk about that, I think the likelihood of having a successful outcome is extremely high. In our practice, our incidence of infection or non-consolidation of a routine socket graft is virtually nil. Sometimes I have to wait a little bit longer. Sometimes I might be regrafting the crestal area if some bone particles have been lost prematurely. But really, the outcome for those grafts are extremely successful.
Dr. Rosenlicht, we do have a question.
Sure, go right ahead.
What testing do you do to see if your graft is ready, and at what time intervals? What exactly are you looking for radiographically and clinically?
That's a perfect question. So what I like to do is I like to give a little bit of local anesthetic just to the gingival tissue above where I've done the socket graft. And then I don't use an explorer. I use a perioprobe. And I'll actually push it through the soft tissue. And when I hit bone, if I can push it down and enter into that graft, I don't think it's ready. But if I stop at that point and I can feel some good resistance, then I'll make a determination that the graft is okay, has matured or remodeled enough to go ahead and place my implant. Because I know my implant is also going to now heal for a number of months, and that graft will continue to mature and remodel, and will be satisfactory. That's a very good question. But I get an x-ray to see how it looks on x-ray, and then I clinically try to assess the area. And I think by doing that, you'll minimize any problems by placing your implant too prematurely. I hope that answers the question. Any other questions? Okay, so why do we get bone loss after an extraction? Well, you can lose the clot because it's not there long enough for osseous maturation, like a dry socket. And we know that in 40 to 60% of the time, when we take out a tooth, if we do nothing, that tooth anatomical area is going to shrink down. Now, sure, sometimes we'll take out a tooth and we don't have any bone, bone loss. Let me get rid of this thing here. But that's, I think, rarer than the routine case. So I think when the clot's not maintained for osseous maturation, I think when you have a thin buccal plate, less than 1 millimeter, the blood supply to that buccal plate is very, very challenged, and it may resorb over time. So supporting that is important. And if you don't, that buccal plate resorbs over time, and then again, you lose the anatomy of that area. What about when you're doing a traumatic extraction? And I think this really is a problem. I think when we're looking at extractions today, we really want to minimize the amount of trauma that we have, fracturing those teeth, having to take a drill to those teeth in order to remove roots or so forth. So we want to minimize the traumatic extraction, because the more traumatic it is, the greater the opportunity for bone loss or infection you're going to have. And then if you take out a tooth, and now that site is not stimulated by anything, you have this disuse atrophy. So sometimes we consider implants to be something that stimulates bone because it serves a purpose for that bone to be there. So without a tooth or an implant, that bone has no real purpose, and it will change and remodel over time. And then what about the overlying soft tissue? And is that critical to the bone being lost? Well, I think it is, because a lot of times the overlying soft tissue might be avascular, might be very thin, might be infected. So many things can affect it, so that the overlying soft tissue is a critical factor and also for bone loss. So these are the 5 most common things that I think you need to be aware of for bone loss and the changes in the anatomy. So socket grafting and ridge preservation, I think the indications are all extraction sites, all surgical sites where implants are contemplated and the ridge is deficient. The contraindications to doing it might be severe localized bone infections at the time that you're taking out those teeth or treating that patient. Uncontrolled periodontal disease, which we're kind of all aware of, but we certainly don't want to have any kind of uncontrolled problems that could infect our graft or be a problem. What about when the patients say, hey, I can't afford to do that? I kind of look at it sometimes as, can I afford not to do it because I want to do that implant in the future? The cost of doing a socket graft, for many times what we charge for it, is a huge profit maker for our practices. There's no question about it. I think it offers a great service to our patients, but oftentimes I will give that away to my patients because I know down the road, more than likely, they're going to want to go forward with an implant, and it'll be much easier for me to do and much easier for me to sell or talk the patient into rather than sell when that time comes for that patient to make the decision. So we got a tooth, it's broken down, needs to come out. We want to atraumatically extract it. I actually use an instrument called a power tome, which is nothing more than a hydraulic periotome. We'll talk about that, I think, at the next one when we talk about technology. You can use extractors, you can use piezo surgery, whatever your favorite method is of atraumatically extracting teeth, I think you should do that. But what you want to do is make sure that the tooth is extracted with minimal bone loss. You want to clean out and really make sure that there's no soft tissue, no debris, no granulomas within that tooth socket. Some people advocate preparing that socket with some small perforations just to initiate a wound response or get some underlying bleeding. I will do that if there's no bleeding in the socket. If I find that the socket bleeds, I just vigorously curettage it and place the bone graft into the socket. And here you can see I've used a combination of a synthetic material, which is that white particles that you can see, in conjunction with demineralized freeze-dried bone, okay? And I typically use this combination today, even though these slides are old. But for me, that combination works great. I use the synthetic material as an expander, keeps the cost down a little bit. I find it also maintains that ridge or that graft a little bit longer so that it has adequate time for remodeling and resorption over time. And then we get a successful outcome. So our technique is an atraumatic extraction, thorough debridement of the sockets, loosely compaction of the graft. Don't densely compact it because we want it to be able to be infused by the blood that's in the area, because angiogenesis is really what we want. We want a blood supply and a circulation to take place within that graft so that it becomes viable and is able to remodel over time. I like to cover the top of the graft with a collagen membrane. I think it gives me a little bit of a thicker gingival response. And then over that collagen membrane, I place a TefGen membrane that we'll show you in a second, just to really isolate the underlying graft and collagen from saliva and any kind of bacteria or trauma that can be affected as the patient heals. And then again, you can let this remodel from 2 to 6 months. Sometimes I'll do immediate implant placement in extraction sockets in conjunction with bone grafting. Sometimes I'll put the implants in and delay their restoration, and we'll talk about that also. So again, here's a tooth. This is that same tooth. It was fractured off. It was tooth number 9, I believe. It's just been supported here by a orthodontic wire so that the patient doesn't go without the tooth before they get to our office. Here's that tooth again, the root that's remaining. It's atraumatically removed. And here on the opposite, on the left, on the right side, you can see what we've done is we've actually placed the TefGen membrane and we've placed it under the free gingival margin of the socket. And then with some overlying suture, whether it be silk, whether it be Gore-Tex, whether it be a resorbable material, we basically just make sure we coapt that tissue so that saliva, any food debris is actually going to be protected from getting into that graft. And I have to tell you, this seems to work out pretty well. We take the sutures out in 7 to 10 days. I leave that membrane in until it either comes out on its own or I'll take it out in 2 to 3 weeks. Okay. Sometimes if it develops a little bit of an odor or the patients can't keep it clean, I'll take it out a little bit before then. But usually, you know, they can maintain it. Sometimes we'll put them with some oral rinses, but we don't want them to vigorously rinse out. We don't want them to dislodge any graft materials. So here you can see what we've done is we've placed the temporary restoration over that site. We like to have Ove Pontic, so I'm not quite sure if this is going to show an Ove Pontic or not. But here you can see how thick the overlying soft tissue developed after the socket graft had matured. Now this is at 2 months. So you can see we still have some graft material there. You can see we have some graft material that's also on the underside of the flap. But notice what we've done is we've done a papilla sparing incision, because I think that that's important, especially in aesthetic areas, so that we can try to minimize that black triangle or papilla from resorption when we're doing our grafting. In fact, that's one of the strong reasons for doing immediate implant placement and provisionalization is maintaining the existing architecture of the patient and not allowing it to change while we're waiting for things to heal. And I'm going to talk more about that in July also. But once we have the graft material in, and here you can see some of the materials that I've been using over the years, the tricalcium phosphate, mineralized freeze-dried bone, whether it be cortical or cancellous. I happen to like the smaller particle sizes. I do not use anorganic bovine bone in extraction sockets. I just find it lasts too long, and I've had problems with it over time, not fully remodeling or resorption. I think collagen matrices are very, very good and can be used over the grafts. There are some collagen matrices out there now that have incorporated HA, resorbable HA, and some graft materials within them. I think you can use that. Some of the synthetic bone proteins can be placed into these tooth sockets, but the cost, I think, is a little bit prohibitive when we start using these types of materials for routine socket grafting. And every single day, it seems like there's a different product on the market that you can use. My particular cookbook approach is to mix some of the local autogenous bone or allograft with some of the resorbable tricalcium phosphate, and then I just cover that up, and I find that to work out very well. But whatever anybody wants to use, I think, again, this is a decision that's made by the surgeon based on the site that they're going to be operating on, based on the materials they feel most comfortable with and have had the best results with. And handling characteristics are definitely important. And I'll talk about how we handle some of these materials also, but that's going to be for July. So what are some of the critical factors that ensure success when placing implants in extraction sites? Well, as I said before, I think the thickness of the buccal plate and the soft tissue biotype is important. Stabilize the implant with less than 2 millimeters of space around the implant. Now, I actually have placed implants in extraction sockets where I've had greater than 2 millimeters of space. When I'm doing that, I'm usually doing it with some concomitant bone grafting to fill in that void. I just believe that the clot that would form around an implant in a large extraction socket would break down sooner than soft tissue could then develop within that area. So I have a tendency to always want to graft my sockets, even when I'm placing implants into an immediate extraction site. You know, I think compliant patients are important. You know, all this stuff goes out the window if you have a non-compliant patient. If you have a smoker or somebody who's not going to take care of the site, they don't take care of their mouth, and they're going to not brush their teeth. Compliant patients are a key issue in determining how you're going to proceed with your patients and just how many more things you might do in conjunction with your treatment. I think you can ruin a procedure by not picking the right graft materials. So spend some time and really examine which materials are most appropriate for you and your patients for the procedures that you're doing. And again, I don't want to have any active disease adjacent to any of these procedures when we're thinking about placing implants into extraction sites. So let's talk about that. You know, when might we want to place implants in extraction sites and even do an immediate provisional restoration? And I do a fair amount of these. I actually like to do immediate provisional restorations when the patients come in and they meet the criteria that we just talked about. So here's a patient who has tooth number 10 with a post and core and an endo that fractures on this patient. She happens to be a hygienist of one of my referring dentists, and there you can see the extracted root and the post of the crown that was placed, you know, on that restoration. This is what she looked like pre-surgically with the tooth in place. She had all kinds of obviously restorations, some gingival recession, but otherwise a healthy mouth. She was a hygienist, so she was a very compliant patient. She did really not want to have any kind of removable appliance put in her mouth, and I felt she was an ideal candidate for the root extraction, implant placement, concomitant grafting, and a provisional restoration that would be placed on it. And what better provisional restoration would be her own original restoration? So here we take out the tooth as atraumatically as possible. We're putting the implant in. We are checking the torque values, which we'll talk about in a second also. And that's that primary fixture mount transfer that I had developed a few years ago and was purchased by Zimmer. So once I have the implant in place with that fixture mount transfer, I typically take an impression. So now I have an impression to give to my restorative dentist of the implant in bone, and he doesn't have to even go through that process. And then within our practice, we have a number of temporary abutments that we have. So we'll put a temporary abutment onto that patient, we'll prep it, we'll hollow out the patient's existing crown, if it's a natural crown, or if it's a crown that had been fabricated, for a restoration. We'll actually hollow it out, and then we'll put some composite in there so that we get an adequate adaptation to the temporary. And then we're done. Patient leaves, making sure that the temporary is not going to be under any kind of pressure. We keep it out of occlusion. It's a provisional restoration that's basically there for aesthetics more than anything else. But what's its benefit? It's going to support and maintain the bone. It's going to maintain and support the soft tissues that were there. We have immediate aesthetics, and if everything works out right, and the way I tell this to patients is there's a slight increase in potential complications because we're doing more than we would if we just place the implant as a two-stage procedure. And I tell them that the risks are about 3 to 5% that they may have a problem. And that lets them know that they're also responsible for some of the success if they want to have this done. That's why a compliant patient is so critical. And we really need to have a minimal amount of fixation of that implant in bone before we would even consider doing that provisional restoration, so that no one's ever promised that we'll be able to give that provisional restoration to that patient. I used to always require 35 Newton centimeters of force to be able to do it, but I've actually dialed that down to 25 Newton centimeters. But I think it's a personal opinion that you have, that it's your comfort level. But certainly 35 would be a very adequate amount of force to have on that implant to make sure that it would support the overlying provisional restoration. So how do you know you have 35 Newton centimeters of torque? Well, you can touch it and take a guess. You can tap on it, take a guess, or you can measure it with some radio frequency, or you can put a torque wrench on it and get a torque, determination. But there are ways of accurately determining the torque value or the fixation of your implant in bone. So we have two methods of doing it in our practice. One is the implant stability quotient that we have from a piece of equipment from NEOS, which basically uses radio frequency to determine how stable that implant is in bone. And what's nice about this particular stability quotient is it tests the implant both in its lateral forces as well as in its shear forces. So we're able to test it for the resistance to shear, and with torque measurements and a torque driver, all you can do is test the shear forces. With the implant stability quotient, we can test both shear and lateral movement. And really the lateral movement is what kind of is the most detrimental to our implants, in often cases. So that's kind of a little bit of a very brief overview of socket grafting, and then taking socket grafting and then moving into placing your implant and doing an immediate provisional restoration, or making a determination that you'll bury that implant and then do a secondary procedure. I'm going to end up, because I think we're just about right on time, in the next 5 or so minutes to talk about a little bit of sinus augmentation. Now, some of these numbers have changed because of the fixation ability of some of our newer implants. But typically, we would be considering doing a sinus augmentation when we have less than 5 millimeters of residual bone. Actually, if I have less than 5 millimeters of residual bone, I can still place an implant and do concomitant augmentation, because I want to make sure that my implant is going to be stable in bone if I'm going to be doing them concomitantly. You know, sinus augmentation can be done through a lateral window, which is really what I consider an augmentation. But if I'm going to be doing an augmentation through the actual implant preparation site, then we call that an intrusion. And there are a number of nice techniques that you can use to elevate the sinus floor without a lateral antral approach. And then using, you know, the sinus augmentation is also highly successful, but it does have some potential for having problems, especially if you violate the membrane. And when you violate the membrane, you can, you know, initiate some bacteria or some things that might cause the graft not to be as stable or stay where it needs to be. So using a PRP or PRGF or some of these other materials to make our graft a little bit more firm and stable is appropriate. Also, bringing some cells to that site in an area that's relatively avascular, I think, is important. Sometimes we'll do immediate implants in conjunction with our sinus grafting, as long as we can stabilize that implant. So here's a quick question. Do you know who and when the first sinus augmentation was done and documented? And this is one of our questions, because many people don't know who did that. I'm not going to tell you who did it. I'll let you answer the question and see if you get that question right at the end of the presentation. I think you'll be surprised who was the first person to do a sinus graft. But here you can see we have a typical, you know, hyperpneumatization of a sinus, which happens oftentimes when teeth are lost. The sinus pneumatizes, we lose bone. Here you can see we really haven't lost bone crestally, but we certainly have lost a lot of bone within the sinus cavity. Again, cone beams show us if we have pathology within the sinus, but look how thin and how atrophic the amount of bone that we have in this area. We can see we've got bone in this first bicuspid area, but as we go deeper back or further back, you can see there's just not enough bone to be able to place implants that will be adequate to support the overlying bridge that we'll be putting on that case. So here you can see that. So in this particular case, we're going to be doing a lateral antral approach to a sinus graft. So here you can see the surgical site, and we're designing our flap before we even think about, you know, doing our sinus graft. So I actually like to make sure, and you can't see it in this picture, you'll see it in some other pictures. Again, a papilla sparing incision. Here I'm actually in the mid-crestal area, and then you can see we've got some great exposure and elevation of the lateral antral wall. I think exposure and having a good blood supply to the flap and making sure that our flap is going to be able to be closed in a non-tension fashion is really key. Now, the approach to the lateral window can be done with a high-speed handpiece, with a diamond handpiece. This is showing one of the approaches that we use with piezo surgery. I think piezo surgery is spectacular because it's able to make a nice bony cut, and it really does not damage the underlying membrane as long as you're careful, you know, with it. And we use it a lot. We use the piezo surgery a lot. We're finding that the newer units are very, very fast and efficient. And there's some studies out there that say that even the bone healing occurs better because there's less peripheral resorption from lack of heat and so forth in these cuts. In the first slide I just showed you, we had used a blade-like approach. This is a piezo surgery round burr, just kind of also showing how we're making the cuts, and you can see the underlying membrane that's there. Once the window is made, and we're making this window high up above where we have the pneumatized sinus so that we're able to get enough graft material in and also not violate where we're going to be placing our implants. So here you can see a typical sinus membrane. This is the intruded lateral wall, which becomes the roof of the sinus. Some people remove that segment of bone and place it over the osteotomy at the end of the augmentation. I actually find that if I take it off, I risk the chance of rupturing that membrane. So I basically leave that piece of bone in place. It acts as a roof to the sinus augmentation. I try to make sure that I go all the way over to the medial wall of the maxillary sinus. So I've got adequate bone there. We'll have the patient to breathe, to see some pneumatization of the sinus. And once we see that we have that done and no perforations, we're ready to graft. If we happen to see a perforation, then we will repair that perforation. There's a number of techniques that we'll talk about in the course in July. Here you can see some gauze. I saturate the gauze typically with just some local anesthetic with epinephrine so that I can start to actually gently move that sinus up, but more importantly, just to get some hemostasis of the area. And here you can see we've got a void there. Here you can see some of the gauze. And again, the preparation of the recipient site and the amount of bone that we have for our initial stabilization, okay? And as long as I have between 3 and 5 millimeters of bone, I think I can stabilize those implants pretty well. If we want to use some stem cells or again, some adjunctive material because we've got a patient with some sinus issues or we have some other things going on, smokers and so forth. Unfortunately, a lot of our patients do smoke. A lot of our patients have diabetes. A lot of our patients have connective tissue disorders. So using some of these adjunctive materials is kind of like a belts and suspenders treatment for success. We use this material called amino MTM. It's a amniotic multipotential tissue matrix that we use. We'll spin down the patient's blood for some PRGF. We make membranes, and we also incorporate this within some of our graft material. And here you can see we're mixing some autogenous bone with some allogeneic bone, and then we're going to mix some of the PRGF with that, which really makes a nice consistent material to be able to place into the maxillary sinus. And here you can see we've loosely packed it into the sinus. We've placed all our implants in position. I actually like to place the graft first, then I place the implants so that I know that the implants are now totally surrounded by the graft material. And again, a nice non-tension primary, sometimes double layered closure, but this is the kind of closure that you want to see. You can expect some swelling. You don't want to have any tension on this. And here you can see the papilla sparing incision that we have. And these patients go on to heal usually extremely well. We put them on antibiotics. We sometimes put them on some decongestants, and we give all these patients what we call sinus precautions so that they don't blow their nose real hard. This is at 3 months, and you can see you almost have an intact lateral cortical plate. And this particular patient had a little bit of that amniotic material placed within their bone graft material. And then here you can see the graft at, I think, 3 months. And this patient is now ready to be restored. And we'll show all the final restorations of these patients. We've got a few more minutes to go. I showed these inlay grafts because I consider a sinus graft an inlay graft. I'm going to end with this last case, as I think it's kind of worthwhile, because a lot of times our defects are defects that are not inlay grafts or inlays. They need an onlay graft. So I developed a few years ago, and KLS Martin now markets it, a screw. It's called a 10 screw with a very broad head on it. And it's got a smooth shaft to it, and then 5 millimeters of threads. And then this shaft comes in a variety of different heights, 3, 5, and 7 millimeters, to be able to give you the space that you need for the augmentation for that area. And what this 10 screw does is it allows for a particular predictable amount of space. It protects the displacement of the graft under the membranes. Its broad head helps prevent tissue dehiscence, and it's actually relatively easy to use. So that's kind of what it looks like. So here's a simple case where we have a defect, where if we put an implant in, we know we're going to dehisce this area. So we do some preparation of the site with some small perforations that initiates a wound response and gives us some underlying bleeding. And then we simply just place the 10 screw in position. We determine what our best graft material is going to be for this particular case. And here I'm using an overlying membrane after I've grafted the area. I'm not using these membranes anymore. I'm finding that the 10 screws support the overlying tissue more than adequately. Sometimes I'll use 2 10 screws instead of 1, and just close over the area again with that non-tension primary closure. And then we go back at 4 months, and here you can see the membrane. This is kind of the result. I'm sorry for that fuzzy picture. And then this is the kind of augmentation that you have. And here's your 10 screw that's actually supported the semi-rigid membrane with the titanium struts in it. And here you can see the bone graft. Now we're taking the 10 screw out. We test to see how dense it is. Do our preparation for our implant. Place our implant now with no dehiscence. And then you can see on this x-ray, this is the pre-op. You can see the concavity that we have in the buccal plate. And then here you can see the membrane in place. But look at the augmentation that we have. And here you can see the 10 screw. And I believe this was a 5 millimeter augmentation. And this patient goes on to have restoration. But I want to thank you all for participating. This is the first time I've ever done a webinar without seeing any people in the audience. So hopefully it was beneficial. This was just a little bit of an overview of some extremely important topics that really need a lot more discussion. Hopefully I'll see you back, or you'll hear me back on the 29th. On that night, I'm going to talk about the oral pathology review, an update on HPV and oral cancer. I'd like to talk about implant treatment planning and virtual navigation and innovations in surgical treatment. It'll be kind of similar to what we did tonight. And I want to thank you all for attending. And Joyce and Lacey, I guess that's it. If there's no other questions, I guess we can call it an evening.